Great. Welcome everyone to the Special Populations Core 2023 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thank you for joining us for today's presentation. We're very excited to have Dr. Greta Bushnell and Jim Lloyd with us to discuss an ongoing study that examines antipsychotic medication use among Medicaid-enrolled children and identifies the implementation of state safe use initiatives for these medications. Before we jump in, if you have any questions during the talk, please feel free to unmute and ask throughout the presentation or drop a question in the chat. We'll also have time at the end for Q&A as well. To get us started, I'm going to hand it over to the Director of the Center for Health Services Research here at Rutgers and lead of the New Jersey Act Special Populations Core, Dr. Stephen Crystal, to introduce Dr. Bushnell and Jim Lloyd. So Steve, over to you.
It's such a pleasure, and thank you, Greta and Jim, for doing this. This is a wonderful collaboration. Greta Bushnell is a pharmacoepidemiologist who focuses on studying the use, effectiveness, and safety of pharmaceuticals prescribed to treat mental illnesses for young people. She joined Rutgers in 2020 and is an assistant professor of epidemiology at the Rutgers School of Public Health and a core member of PETS. She earned her PhD and MSPH in Epi from UNC in Chapel Hill, a very strong Epi program, and held a postdoc with the Psychiatric Epidemiology Training Program at Columbia University School of Public Health. Her research has been published in JAMA Psychiatry, Pediatrics, JCAP, Pharmacoepidemiology and Drug Safety, and other distinguished journals, and supported by NIMH and NIDA. Jim is a research specialist at the Rutgers Center for Health Services Research. He serves as the project director for several studies examining how states are promoting the safe use of antipsychotic medications, in particular an ARC-funded study of state oversight mechanisms for antipsychotics, which has been a subject of work in our center and a subject of a great deal of policy activity at state and federal levels over the last 15 years. So a very interesting and important area. He's also in the work group tasked with helping to establish a New Jersey Community Health Worker Institute. Previously worked at the Center for Healthcare Strategies for 5 years, consulting with Medicaid agencies, safety net providers, and payers on issues of health delivery system and payment reform. So looking forward to an exciting discussion, and over to you guys.
Thanks, Steve. I'll start off. I'm just going to share my screen and get my slides up. I'm going to give some background on the study, kind of where it came from and what we're doing broadly. And then I'm going to hand it over to Greta to present a bit on some of the results, the exciting results that we have. Does everybody see that?
Yep.
Great. So this is study. So first, I'll just go into a bit of background. As Steve had mentioned, in the 2000s, about 15 years ago, policymakers and advocates began to see high rates of prescription for antipsychotic medications among children. This really kind of started in the foster care systems initially, where you have a situation where children are kind of wards of the state, to use an anachronistic and probably inappropriate term, but where the state kind of has more oversight over what's going on. AP medications, and I'll refer to them as AP through a lot of this. I mean, they're heavy duty medications, right? There are potentially serious side effects for these. There are metabolic issues that arise, and they just, have a very serious impact on, the children that are taking them. And so while we recognize that there are a certain number of children that are, clinically indicated for AP medications, and they should receive that, and that is the care that they should get. The goal of these policies that states have been putting into place is safe use. We're not saying, reductions in use. We're not saying elimination of use of these medications, but it's safe use. It's making sure the kids that need them get them, and making sure kids that might not benefit from them as much as they would perhaps other medications, perhaps counseling, any other kind of care that they could receive, that they are getting them. So that's why we use the term safe use. The work here that I'm going to detail and that will have informed Greta's results is an AHRQ funded study on the safe use of antipsychotics among Medicaid enrolled children nationally. And here at the center, it arose from some earlier work looking at foster care populations. Again, as I mentioned, that's kind of where the initial momentum for this came from, nationally, policy-wise. And the earlier work that was done investigated antipsychotic use among foster care kids in several states. It was Ohio, Texas, Washington, and maybe Wisconsin, I think. And that work actually led to the development of several quality measures that have been adopted nationally, including first-line psychosocial intervention and metabolic monitoring for kids on APs. And it was a really interesting study. It involved, working with foster care advocacy organizations in some of these states. It involved working with managed care organizations in Texas, Seattle Children's Hospital in Washington. It really informed the field nationally and a lot of the work that we're carrying forward in the AHRQ study here. So the structure of the study that we're looking for, there are really kind of three aims that make up the study. The first is to gather detailed information about the promotion of safe use. So that is broken up into two parts. One is a survey of Medicaid medical directors to learn about programs implemented in their states. That we're working with the National Association of Medicaid Medical Directors to get that out. It has run into some challenges, which I'll discuss in a bit, but we're getting some really valuable information about what's happening out there. And the folks that we're talking to in the larger community are really interested in us kind of circling back and presenting some of that information to them. One of the goals of this study, in addition to pushing the field forward nationally and creating good science and important research that could help inform evidence-based policymaking for kids who need antipsychotic medications, is also just to disseminate and communicate this back to policymakers, which you'll see a bit in a couple of these aims. The second half of the first aim is 8 case studies of states. We selected 8 states to provide important lessons for other states that are valuable, that provide a good diversity of policy environments, good diversity of geographic environments, and a good diversity of kind of what they're doing. And I'll get into that in a bit more detail. And then from those 8 case studies where you do key informant interviews with folks in there to get a kind of clear picture and timeline of the implementation of their safe use policies, and then draw lessons from those qualitative interviews in kind of discussing how the states implemented these things, but then also using the information from those qualitative interviews to develop timelines to kind of lay over the quantitative analysis that we're doing, so we can get an even better sense of how the policies could have informed outcomes for the kids in those states. So the second aim is a quantitative data analysis using max TAF claims data that we have here in the center, looking at utilization and outcomes, not only in the case study states, but also nationally, since max and TAF are nationwide data sets. The initial findings from that we're going to see in a couple minutes when I pass it over to Greta. But it's as we do at CHSR, it's a mixed method study, putting together the key informant interviews from those case studies and then the quantitative data analysis to really get as complete a picture as possible in those states. And then also looking nationally and trying to find out further opportunities to do research nationally and learning more about the states that we're not necessarily going into with the case studies. And the third aim is dissemination of the results. So, I mean, of course, we're going to disseminate through, high impact journals and create, lots of excellent academic literature from this, as we've already begun to do. But we're also going to develop a toolkit for AHRQ for other state policymakers to develop their own programs. You know, policymakers, if you work with folks in Medicaid offices, they really want to know what other states are doing, and how it's working for them. And you know, we have this incredible opportunity with this study and the capabilities of our center to really develop the evidence, you know, for these programs. Or, I mean, I don't think against the programs. I think, you know, a lot of these programs do work. They're the things that we've kind of selected are based on evidence and literature already. But really providing them with detailed information to make good decisions to promote safe use for the children in their states. So how's the study been going? Well, there was the COVID-19 pandemic that arose right when the MMD survey was in the field. And so initially we received few responses as Medicaid agencies were scrambling to, you know, react to the public health emergency. We've been doing outreach and we are receiving more. So, you know, that's certainly moving forward, and we're gathering a lot of really valuable information on what's out there. We developed a list of case study states by reviewing the available information on what policies they have out there. We also consulted with experts. We contacted folks we know in those states and in other states about you know, what's most salient in terms of what people are doing. We talked to a stakeholder advisory board that we have for the study, and the organizers of the Medicaid Medical Directors Network over at Academy Health. They're incredibly knowledgeable in this area, as well as some Medicaid medical directors that we know that are operating and have really focused on safe use of antipsychotic medications. And then the interviews with key informants in those case study states, they're progressing. We're doing them. We're learning a tremendous amount. It's really fascinating what's going on in so many of these states, and just developing deeper understandings of how these policies are being implemented. And then some things to warn future states about in terms of how they might want to implement such things, and you know, where things are working, highlighting bright spots. It's really interesting, and I can't wait to start more fully kind of integrating it with the quantitative data. So the data analysis is also being conducted nationally. We have our team of analysts working on it, and Greta has developed some results that we're going to show. We're preparing to use that with the case study state reports once we get those timelines finalized. We're really producing a lot of really interesting information, and it's exciting to learn about how things are going. So which 8 states are they? The states we chose are Arkansas, California, New Jersey, New York, North Carolina, Pennsylvania, Vermont, and Wyoming. You know, we went through a pretty extensive process to figure out which ones we should focus on. I mean, it looks like there's a bit of a clump in the Northeast, but there's more states there. And I mean, obviously there are benefits to us for studying New Jersey. We're very familiar with the program. We know a lot of the folks there, but we have a pretty good geographical variety there. And I'll go into each of the states a little bit just to highlight kind of interesting aspects of them. So Arkansas, which actually has been studied a bit, so they're certainly open to that. They had a prior authorization for antipsychotic medications, but they phased it in over a number of years. First with the very youngest children, and then slightly older children like tweens, and then all the way up to 18. So one of the things we think could be really interesting to look at is how that phase in might have impacted utilization for antipsychotic medications among children, obviously in those age groups where the prior authorization would apply, but also, you know, the children nearby those age groups. Are there kind of spillover effects into the other ages? And then talking to the policymakers about, you know, why they chose to phase it in slowly instead of just going for, you know, everybody 18 and below, you know, on such and such a date, and whether they learned anything from the implementation that led them to expand it over time. Maybe they had only planned, you know, children 5 and younger, and decided later to expand it. I think there's a really interesting story there potentially, and we're going to talk to the folks there. In California, California is of course an enormous state with a tremendous amount of people. and as I write here, unmatched diversity. You have rural counties in the Central Valley, you have the Bay Area, Los Angeles, any possible kind of diversity is present there in California. The counties are implementing very different programs, and there's a long history of advocacy for safe use of antipsychotic medications in California. And so I think there's a really interesting opportunity to learn something about large states and about implementing such programs in a real variety of environments, also all kind of under one Medicaid agency. So I think a lot of other states have some lessons that they can learn from California's experience. New Jersey, as I mentioned, is quite nearby, and their efforts to promote safe use are part of a larger state effort to improve care for children, the promising path to success. They've really pushed this for the last several years. It's being evaluated by folks here at Rutgers, and I think there's an important lesson to be learned about how the antipsychotic medication safe use policies can be part of a larger effort. It doesn't have to be just kind of pushed just for antipsychotic safe use. If there are other things going on in a state, how do you incorporate these other policies into that? How do you incorporate perhaps different agencies, different divisions within agencies? I think there's something interesting to be learned there. New York, we chose. There are some early successes. So we're intrigued by the fact that there has been some evaluation there. And most notably, New York Medicaid is working with their managed care organizations for improving the quality of care through the development of some quality measures, monitoring of those quality measures. And that's been part of the early successes that they've seen. Medicaid managed care is probably the majority of Medicaid lives across the country. And New York's relationship with their MCOs, I think, could be really valuable and full of lessons for other states. North Carolina has a nationwide program called A+ Kids, and that is a state registry to document aspects of prescribing these medications. It's not formally a prior authorization program. It's somewhat similar to it, but when doctors order antipsychotic medications, it becomes part of a state registry. The state can kind of oversee some of that. A lot of their pharmacies are linked together in kind of like a data sharing organization. And it's a way to promote the safe use without the potentially blunt instrument of a prior authorization kind of overnight. And so we want to see how North Carolina implemented that, what was necessary to put such a program in place, and how they did that. Pennsylvania has a long history of promoting safe use for antipsychotics in the foster care population, which, as I mentioned, is where a lot of this work came from originally. And they have a number of programs in place to promote the safe use. They have a call system, so physicians who are wondering whether they ought to prescribe antipsychotic medications, they can call some experts at the Children's Hospital in Pittsburgh. And they have a Medicaid agency who's very open to evaluation and participating in research. And again, Pennsylvania is another one of those states that contains a lot of diversity. There's kind of Pittsburgh on one end, Philadelphia on the other end, and then a lot of rural areas in between. And so I think there could be some interesting lessons there. Turning to small state with an overwhelmingly rural population, we have Vermont. Vermont was another early mover in the safe use space. They've really focused on this a lot. And what they've done in their Medicaid program is something called the Vermont family-based approach, which is kind of looking at the family as a unit for improving care in their Medicaid program. And then, so similar to New Jersey, which is really focused on improving pediatric care, Vermont is taking this family-based approach. And then, as part of that, they have a number of safe use policies for antipsychotic medications. And we think it'd be interesting to see how that works within the family-based approach, which is really innovative and something definitely interesting to look at. And our last state is Wyoming. they have shown really tremendous initial success in promoting safe use. Their Medicaid medical director, Dr. James Bush, is on our stakeholder advisory board, and has been a real champion of safe use of antipsychotics for basically his entire career in Wyoming. And as part of that, they developed a statewide consultation program with Seattle Children's Hospital. So any physician in Wyoming can call up the experts at Seattle Children's Hospital, who are, a nationwide leader in promoting safe use, and determine whether or not this fits for their patient, what other options may exist. And it's really an interesting example of a whole state participating in a telephone consultation program, and working with experts elsewhere. So that's kind of where we are now. The next thing to do is talk about some of the initial results we have from our quantitative data analysis, and I will turn it over to Greta. Greta, do you want to share your screen? I think that's what we're doing, right?
Yes, I will share mine. Thank you. All right, we should be good to go. And anyone can, well, I don't have the chat open, but let me, if there's any questions, feel free to jump in, or this is just about a little over 10 minutes, so I won't be too long. Thanks for inviting me today. So as Jim mentioned, I'll be presenting on some of the, I guess, the first piece of some of the analyses, just really looking at some nationwide trends. So a little bit of this will be an overview from Jim mentioned, but I'll be brief. So there are a variety of antipsychotic medications, both first and second generation, and many of these carry some FDA approval for pediatric conditions that include for schizophrenia, bipolar disorder, irritability associated with autism or Tourette's disorder. But these are commonly used off-label. So for conditions such as ADHD, conduct disorder, depression, anxiety, along with some other mental health conditions. And in part because of this growing off-label use in the early 2000s, there was really this sharp increase in antipsychotic use in children. And here's just one example of that work. This is by Steve Crystal's group. The bottom line is a privately insured children, and this is a prevalence of antipsychotic use, and the top line being children insured by Medicaid. So really note, quite a sharp rise in just those few years that Medicaid is being observed here, and quite a bit higher also than the privately insured population, although this increase was in both of these groups. And then for another example of this increase that was seen in the early 2000s, this is a study by Mark Olfson that looks specifically in young children, so preschool age children, ages 2 to 5. And this is a privately insured population, but that same increase in antipsychotic use was also seen in that young age group. And this growth was concerning, given that for many of these indications, there's really a lack of evidence that antipsychotics are effective. And then there's also some potential safety concerns, such as type 2 diabetes, weight gain, cardiometabolic, and also some unknown long-term safety concerns for these children who may end up being on these medications for years. So in reaction to that, several states, as Jim was going through, and organizations began enacting policies and developing means to try to address and reduce this inappropriate pediatric antipsychotic prescribing. So these included a variety of measures, including prior authorization policies, population level monitoring, the development and publication of professional guidelines, and also the development of quality metrics. And so following this, some subsequent more recent analyses show that the antipsychotic use did appear to stabilize and even slightly decline in children. So this was also from Steve Crystal's group, and this looked at Medicaid data, again, stratified by foster care. But the overall Medicaid population, it's hard to see on the scale, but it did peak in 2008, and then it seemed to stabilize. So it seemed to be that maybe these measures were having an effect and starting to bring down or at least stabilize antipsychotic use in children. And then here's another example from privately insured children. These are young children ages 2 to 7, also seeing quite a bit of a decline in antipsychotic use during that period. And some of these policies were more specific to children enrolled in Medicaid, but some of the declines were seen in privately insured children were thought to be potential spillover effects, given that a lot of the providers do treat children in both Medicaid and in privately insured. So, however, at the time that we were really unaware of any recent published analyses that have looked at antipsychotic trends nationally in the Medicaid population. This paper went up again till 2010, and there were some individual states that had provided updated trend analyses, but there wasn't a clear nationwide what these trends look like past 2010. And then additionally, we also knew in the US that antipsychotic use was more prevalent in white children, but it wasn't clear if the trends and some of these declines would also be seen across racial and ethnic groups. So therefore, this specific project, we aim to look at the trends in antipsychotic prescribing overall and by race from 2008 to 2016 in US children who were enrolled in Medicaid. So for the analysis, we used Medicaid data from 2008 to 2016, and 2016 at the time was the most recent year of national Medicaid data that we had available. We had data from 45 states, and this data is an administrative claims database. And from this data, we're able to get patient level information on insurance enrollment and healthcare encounters. So we get details on inpatient, outpatient services that individual receives, along with their dispensed pharmacy prescriptions. We included children ages 2 to 17 who had full year enrollment in that calendar year, and excluded those with dual eligibility and in long-term care facilities. We define antipsychotic use as just one prescription within that calendar year period for any of these either first or second generation antipsychotics. And then among children who did fill an antipsychotic, we look closer at what psychiatric diagnoses they received during that calendar year. And these are classified into mutually exclusive groups. And we rank them to try to order them best by the level of evidence that's available for antipsychotic treatment. So for example, if a child had a ADHD diagnosis and a bipolar diagnosis, we group them under the bipolar disorder diagnosis as potentially the more likely indication in which they initiated the antipsychotic for. And the analysis was fairly straightforward. We were really just looking at the prevalence of antipsychotic use out of the whole eligible population in Medicaid. We stratified by age, sex, and race. And then when we were looking at stratification by race, we limited the primary analysis to 26 states that were deemed to have low or medium concern quality of the race data in 2016 based on the DQ data atlas at the time. We did some sensitivity analyses where we included all 45 states and then included that category for unknown or missing, and then even more restrictive where we required all states to have at least less than 10% missingness each year of the study. And then lastly, we just described the diagnoses among children who did receive an antipsychotic. So the results over here, just a snapshot of antipsychotic users here in 2008 and then in 2016. Each year we had about between 300 and 400,000 antipsychotic users in this population. About a third were female and very few were in that youngest 2 to 5 age group. The majority were in that 6 to 17-year-old age group. But these are really the overall trend findings. So we have the number with antipsychotic, our denominator, this is children enrolled in Medicaid, and then the percent with antipsychotic use. And so overall, quite a bit of decline from 2.3 to 1.3, which was a relative change of 43%. And then here we stratify by age and sex, and overall there are similar trends in this decline. I think one thing to note is really the large variation you get in prevalence. So in males, in 2016 we're at 3% in teenage males, but females, I think this is about at 0.1%. So really a range in prevalence by age and sex. The largest absolute decline was in males, and then it's hard to see, but there's quite a bit of a decline in these youngest age groups, and the age 2 to 5 year olds is where we saw the largest relative declines in prescribing. And then here are the trends by race and ethnicity. Again, quite a bit of variation in prevalence across the race and ethnicity categories that we were able to evaluate. The largest absolute decline was in white children. It declined about 1.4% over our study period. But the relative change was actually fairly similar across the groups that we were able to evaluate. And then here is that sensitivity analysis I mentioned. So the solid line is the primary analysis that included the 26 states. The dotted one is all states, so all 45, and then that slash one is limited to the 18 states that have we were trying to restrict to states with better quality race and ethnicity data. Overall, trends were actually, I think, more similar than I thought, especially considering the difference in states between some of these subgroups. And then lastly, we were looking at the diagnoses that children received in that calendar year in which they received an antipsychotic. So up top here, we looked at 2008, 16, and then we also looked at a time period in between, and this was just in the year before Medicaid expansion occurred. So this is a proportion who had any diagnosis for an FDA-approved indication. And it does seem like this, may have increased over time, which would be, I think, a positive sign, and might suggest that more of these children on antipsychotics do have an approved indication. And here are all the mutually exclusive groups. So again, just as an example, so in 2016, let's see, 5% of antipsychotic users had a depression diagnosis and not a higher order diagnosis is how we did this table. So a few of the biggest changes we have in pervasive developmental disorders increased quite a bit. So in 2016, we have a higher proportion of antipsychotic users with a pervasive developmental disorder diagnosis. And then some others didn't change too much. I mean, ADHD diagnosis is slightly smaller, but not as much of a decline, I think, as you might hope, given the lower evidence out there for antipsychotic use for this indication. And then just some of the primary considerations, just to note, so the trends that we observe might be, or not likely are, influenced by some of these underlying shifts in the population. So Medicaid expansion did occur in 2014. The data completeness and quality might vary across states. Some states had fee-for-service versus managed care. Our study was restricted to those with 12 months of continuous Medicaid enrollment. So we did exclude those with more variable enrollment in and out of Medicaid. We're unable to measure actual medication use, so we're only looking at filled prescriptions, and we only required one prescription filled in our definition of antipsychotic use. And then, of course, we don't have the access to the true clinical indication for these medications. And just to conclude, we did see the sizable decline in the national prevalence of antipsychotic use among children enrolled in Medicaid. We saw this across the age, sex, and racial and ethnic groups that we studied. But we do still see that majority of antipsychotic use does seem to be in children without an FDA-approved indication. We observed antipsychotic use to be higher in white children, which is consistent with prior research. The extent to which the higher use in white children reflects overprescription or reflects underprescription in non-white children, I think, is a key question to address in future research. And examining these trends is really just the first step in that. But overall, as Jim was mentioning, these national declines that we observed in this particular study really occurred in the larger context of these state-level policy changes and updated clinical guidance. So I think the future work of the larger study team will be able to dive more into specific effects of these policies and the specific changes they had on the trends. but I look forward to any questions and comments.
This is great. I'm just waiting a moment to see if somebody else wants to jump in, and if not, I will kick off the conversation. But anybody else want to start? I'll leave a awkward moment. Okay, I'll just put a couple of questions out there for discussion with the panel, and then hopefully others will be interested in jumping in with questions or thoughts. So what I thought would be interesting to talk about, obviously the implications of this are very substantial, but three of the things that, or four of the things that really come to mind that are particularly current are the impact of the children's mental health crisis during the pandemic, something we can potentially look at with the IQVIA data through 2022. The whole issue of if kids who are having problems, and I think it's safe to say that the kind of kids that historically were receiving antipsychotics were certainly perceived as having behavioral health challenges. The question was whether that drug was all that our healthcare system could deliver to them, or the best thing for our healthcare system to deliver to them. So this whole issue of access to psychosocial services for kids with severe emotional disturbance, including those whose conditions have sort of been flagged, if you like, by the fact that physicians and families are moving forward with antipsychotic treatment. So we have this metric that is an official HEDIS metric, which is the psychosocial treatment metric for antipsychotic treated children, that asks whether kids who are treated with antipsychotics received previously or concurrently psychosocial intervention. I think this metric is particularly relevant as the needs for mental health services for kids are only increasing. So the potential for looking at how states are doing with regard to that metric, the metabolic monitoring. So I'd sort of like to encourage comments from any of those participating in the discussion or from the panel members about what the most promising directions are with these data to proceed from here. Peter, did you have a thought?
Well, I just had I don't know if I'm responding to your question there, but I was curious if you've looked at any international data to look at medication use for antipsychotic use, because I'm just thinking of the study that like Steve and Sharon and some others on our team did, looking at prescribing of certain medications internationally. Was it for ADHD, Steve? And yep. I'm curious what this looks like international, or opioids. It was actually for opioids most recently. And I'm wondering, is this like kind of an American, more of an American thing to prescribe? I mean, I know so little about this area, but it does seem to me like
it's absolutely fascinating to look at the cross-national data. One of the things I was surprised by with the opioids paper is that the United States is no longer looking like quite as much of an outlier as we used to look like. For children's psychotropics, I think you also have a lot of variation. And that paper it's a very complicated study, largely unfunded. So what it required, brought together by a group of investigators at Hong Kong University, was reaching out to different groups of investigators who had access to national pharmaceutical use data sets and doing sort of parallel analyses, and was a very effective technique that that ADHD paper has been incredibly well cited. The opioid paper, I think, Sharon, is still floating around, like waiting for people to finish getting it ready for submission. And I was advocating for that group, with that group, for an antipsychotic study. So far, it hasn't happened. Hong Kong, as many of us are aware, has been having a lot of other problems related both to COVID and to sort of being swallowed up by China, and severe challenges about governance. So it's been disappointing that consortium hasn't moved forward. In general, we are, I think we tend to be on the high side, as with most drugs, but not as much as one might guess. There's a few older papers in literature about it. Greta, do you know anything about this literature?
No, I don't. I remember that group, though. I think they didn't do antipsychotic because at the time there was a recent national international comparison of countries, but by now that's actually probably a bit outdated. But no, I do not remember. And I think that group was also looking at like antidepressants next, was on that list. But
Yes.
Yeah, before antipsychotics, yeah.
Which I have a feeling are not going to be as radically different across countries as some of these other medications. World Health Organization has long been pressing for depression to be recognized as the #2, or in some analyses, #1 cause of loss of quality adjusted years of life. But it's really a fruitful area for research, but it requires these gigantic collaborations, and nobody wants to fund what would be necessary to really pay for all that analysis. So most of that work has been done by groups that sort of are largely funded with core grants to their national government. Not everybody. Pharmacoepi is not in every country sort of purely a function of who can get an R1 grant from their government. It's oftentimes a nation will have a few established centers, and based on their productivity, they will receive a core grant on an annual basis from their governments, or they get support from the European Union. So it's a whole variety of ways that this work is getting done. I mean, if anybody is like super interested in it, you could hop on a plane and go to Bologna in June. Hillary probably wouldn't be opposed to that idea, and just drop in on the what's it called, the ESPA-Comp meeting, where that looks at the drug utilization. But it's an underdeveloped area for sure. Did you have other comments, Greta?
No, I don't think not on that, no. I guess I don't know IQVIA has that international data set now too. So I bet there'll be some results, because I've seen some with other psychotropics, but I don't think I've seen one from that data on antipsychotics. But that might make it a little bit easier than how the other papers were done, with that having multiple institutions involved.
That's a great thought. Yeah. It's always an interesting process getting data from IQVIA. They've already given us so much data, but I think the pandemic era analyses will be really interesting, and that work is within the scope of the PTEC grant that we wrote, and perhaps we can find some students who are interested in that topic. other comments or thoughts from people? I might
Yeah,
yeah, good.
yeah, just to like kind of get back to like what other interesting things to look at. I think the one thing is like racial and ethnic variation in diagnoses for a lot of the medications
Right.
that these kids are getting. You see some of that, and then racial and ethnic variety in utilization. Like what is underlying any of the variants that we see there? Is it, the diagnoses for these kids? Like, is there, some kind of basis for the variation in diagnosis? Probably not. I think that's kind of the next question. Looking at the national data, is seeing how that works out.
I think that's a very good question, and there's an opportunity for a lot of interesting social science, because you have a lot of different factors going on when you look at these racial ethnic differences, and historically the literature would suggest that the externalizing diagnoses that are associated with aggression might be overused in African-American populations, which could potentially lead to more antipsychotic prescribing, but within a given diagnostic category, you have less use by African-Americans, and there hasn't been a lot of good research to understand the reasons for this, but it seems very likely that legacies of mistrust on the part of families are involved. Perhaps also healthcare access is an important factor. Looking at who is prescribing these medications, it takes a lot to get to see a child and adolescent psychiatrist. So, white families with more money may have more opportunities to get that appointment in the first place. We've been looking at Medicaid, but the picture of across where the rates are higher than privately insured, the role of foster care, which is obviously African-American children are overrepresented in foster care. So there's a lot of things that are going on, and there's this concept which I've never seen anybody really write a paper about. It's an extremely sensitive thing to write about, but is there such a thing as a protective disparity? Are there circumstances where mistrust, perhaps to a certain extent justified, is actually reducing certain kinds of risks on people's part? Mistrust is obviously not the basis on which we want to eliminate disparities, but those are sort of some of the underlying currents that I think are like pretty deep in understanding this. Another thing that people don't talk about too much, but it is somewhat intertwined, is that many of the kids who are getting these kind of diagnoses have IEPs, and they are receiving accommodations, and in some cases they are receiving Social Security disability. So this was a concern for Social Security itself, who commissioned a study to try to understand, for example, whether increasing rates of ADHD were to some extent benefit seeking, and because they saw a large increase in the number of kids who were getting disability based on mental health conditions like ADHD. We did a study for them, which essentially supported the idea that their special committee was pursuing, which is these trends are driven by real need and not particularly by benefit seeking. But there's all of these sort of factors going on in the background. And now, of course, with telemental health, you have, there's so many additional people just in the last year or two being diagnosed with, for example, with ADHD, including adults, that there's a huge crisis in the supply of Ritalin and other ADHD drugs. And there's, it's thought by the FDA and other organizations to be driven in part by some of the new sort of lower threshold telehealth companies. So these companies, which we've seen playing an increasing role in medications for opioid use disorder, are also playing an increased role in mental health, trying to meet the need. And inevitably in our healthcare system, when a lot of organizations move in to meet a need, some of them are very entrepreneurial and profit driven, and questions get raised about the quality of care. And there's one particular organization, large national organization, which is kind of melted down, been pushed out of the market by regulation that was accounting for a great many ADHD scripts. So it's quite an amazing drama, if you like. It's all the different levels that play into this, but underlying it all is families that are concerned about their kids. They're concerned about how their kids are functioning in school. They're concerned about aggressive behavior or other kinds of real mental health crisis. And all of that has increased during the pandemic. And they have trouble getting real services. And they certainly have trouble getting real psychotherapeutic services and solid evaluations. But it's maybe not quite as difficult to find a family doctor to prescribe one of these medications for you. So it's a long story. Anybody want to add sort of some more comments on? I think it's an extraordinary area for research. And I think Greta's lucky to be focusing on this area of children and psychotropic medications, because there's so much going on and there's so much to look at, and it has so much consequence for so many kids.
Yeah, I can just add to what you were saying a few minutes ago when looking at some of these differences by race and ethnicity, and is it over or under prescribing, and probably both going on. But we had talked about as a next step, if potentially finding someone who's interested, but looking at among children with the specific indications, how many are prescribed antipsychotic, to see if that might vary, which of course we're restricted to children who have that diagnosis at least. So we're already, within a subset, but maybe to inform the trends a little bit more and try to figure out what is this, are we seeing more over prescribing or under prescribing across these racial and ethnic groups.
So in that light,
interested, let me know.
Yeah. In that light, I'll put out kind of a public service information, public service ad for those who are working with grad students who are interested in this area, and many are. Jim connected us with one who's been wonderful from Gazap, and found it useful to work with us on some of her research. There's another person who Peter has connected us up with. So we have, I think the extraordinary resource that we have right now, besides these Medicare data, is the IQVIA data, because they're so recent and because they're population based, and because one can look at the roles of the different payers, and to some extent the roles of different provider characteristics, like their specialties. So the fact that you get a pretty much full picture, population-based picture of prescribing. Jennifer was instrumental in helping us to write the original PTEC application, which got us this data access award from IQVIA. So for those who were interested, we did not exclude, we did not say that the study was only about adults, although we were thinking more about adults than children. And that is getting us all the mental health prescriptions for kids and adults for, I think, Sharon, is it 2013, 2015 it starts through 2022?
I think that's it, yes.
Yeah. So this is, you know, we're thinking a lot about the medications for opioid use disorder, of course, but during the year or two that we have these data, there's really wonderful possibilities for other population-based analyses, including antipsychotics. And it might be worth looking at sort of antipsychotic use. There were a few papers that were written, like changes during the early stages of the pandemic. But now that we're getting close to officially being behind the public health emergency as of May, you know, 2022 represents a period where the healthcare system had settled down a lot. But at the same time, you had this sort of accumulated backlog of people seeking help, and many of them seeking telehealth. And it's pretty clear from what CMS is doing and SAMHSA that telehealth is not going away. In fact, one of the nuances that I just noticed with the new MOED regulations is that, and I'm not quite sure how they legally can do this, but the initiation of buprenorphine, even by telephone, is waived further going forward in the SAMHSA regs, which I actually thought was barred by the Ryan-Haight Act. So, in other words, this whole changed landscape and the data on the crisis in mental health among kids is real. The suicide attempts, you know, even some increases in suicide rates, particularly among girls. So I think what's been happening in mental health for kids during that time period is really, really an important topic. So just something to hopefully inspire us all that, you know, we have lots to do. Okay, any other last comments? Kylie?
No, I was just gonna flag we're coming up at the end of our time. Unfortunately, lots to discuss though. But just want to thank everyone for joining. And of course, Dr. Bushnell and Jim for sharing your research with the NJAX community. We of course so much appreciate it. Take care, everyone, and we'll see you at the next seminar.